Hope you're having a very nice Saturday, and I hope every session has been informative. Uh, my name is Dr. Gannat Kifle. I'm an emergency and critical care medicine specialist, currently working at Alert Comprehensive Hospital. I'm also the emergency and ICU director there. To say a little bit about our hospital, Alert Center is has identified acute care medicine as one of its focus areas and is working on that specific area. And we've also housed one of the few trauma centers in the country, and the newly renovated ICU has just started working. So we have a training center, and we provide skilled trainings and refreshers for the staff at our center, and also people from different walks of from different parts of the country. We strive to become a center of excellence in acute care medicine, and the other our other interest areas are plastic and reconstructive surgery, spine surgery, and rehabilitation. So I didn't take that much time. It's my pleasure to present the next speaker, Dr. Membah Sultan Mohammed. He is an associate professor of emergency and critical care medicine. He is one of the few intensivists in the country. He's currently working as director of critical care services at St. Paul's Hospital Millennium Medical College in Addis Ababa, Ethiopia. He's the president of the Ethiopian Society of Emergency and Critical Care Medicine. Dr. Membah has led and consulted on numerous national emergency and critical care projects in the country. He's the founding member of the Pan-African Journal of Emergency and Critical Care. He's particularly passionate about developing evidence-based health care system in the country and elsewhere in Africa. Recently, Dr. Membah has collaborated and published the first Ethiopian National and Critical Care Capacity Assessment, which helped in identifying gaps and gave baseline experience for conducting nationwide interventional collaborative studies in acute care. Today, Dr. Membah will be speaking about intensive care in sub-Saharan Africa, results, experiences, and lessons learned for future projects. Questions will be asked later on. So, Dr. Membah, if you can continue.
Thank you, Dr. Gannat, for your kind introduction. Good afternoon, everyone. Can you hear me?
Yes.
Okay. Thank you. So I am presenting on the findings of the National Critical Care Capacity in Ethiopia and what tried to be done in improving the situation in Ethiopia. And one of the effort was the mentorship and coaching program. So I'm going to present that findings also. In my outline, I am going to speak few words on the backgrounds of Ethiopia and critical care in Ethiopia. Then we'll come back to the results of the National ICU Capacity study and the role of locally driven clinical mentorship and coaching program to improve the situation in Ethiopia. So Ethiopia is an East African country, as you know, and probably some of the participants are from abroad. I'm just telling the backgrounds of Ethiopia. So the population of Ethiopia is around 114 million, and now it's 11 regions. When the study is being conducted, we had 10 regions and 2 administrative cities, and the life expectancy of Ethiopians has increased. It was 45 in 1990, and now in 2022, around 64 years of life expectancy. And with epidemiologic shift occurring in Ethiopia, there is also demographic, with the demographic shift occurring in Ethiopia with increasing life expectancy, and there is a demographic change, like non-communicable diseases are becoming common now in major cities. 52% of deaths are becoming related to non-communicable diseases, and sudden deaths are mainly related to cardiac origin, and emergency care and surgical care demands are also increasing, while the communicable and pregnancy-related diseases are still existing. That means in Ethiopia, we are having a triple burden diseases, both communicable, non-communicable disease, and trauma and emergency. So the government is investing a lot to respond to this need, and tertiary care hospitals, tertiary care facilities are increased, and specialty care, super specialty cares have increased, including transplant service, kidney transplant and all. When you come to critical care service in Ethiopia, the history of critical care starts in 1956, then called in Lelt Tsahai Hospital. That means currently it is called Tor Hailoch Hospital, and it took us 37 years to open the next ICU in Black Line Specialized Hospital. By that time, Black Line ICU was established to manage septic shock caused by abortion and malaria, severe and complicated malaria patients. And currently, the epidemiology of patients being managed in ICU, the reports from Jimma, St. Paul's Hospital, Black Line Hospital, and Dese on the Mekelle, most are consistent, and they are managing sepsis, trauma-related head injury, obstetric complications, surgical emergencies, and communicable diseases still. So most of the diseases are treatable, and the age of the patients being admitted to ICU are younger as compared to the Western. Even in COVID, the average age for patients admitted to ICU and days is almost 57 years in Ethiopia, while in a Western nation, it is around 72 years, and some centers it is 80 years. So our patients are younger and having treatable patients. So the investment on critical care is cost-effective or mandatory. So the demand for critical care has increased because of COVID recently, and there is a positive data in ICU capacity in low and middle-income countries, including Ethiopia. So we don't know what is our capacity in Ethiopia, especially during COVID. Are we ready to manage the surge in ICU demand because of COVID? That was a question which was raised during the early 1920s. So 2020s, that means. So the objective of that, the national assessment, was to assess the baseline information on the status of critical care service and the structure, the staffing, equipment, and academic activities in the ICUs, and to identify and prioritize focus area for the scale up of critical care service in Ethiopia. So the method we used to assess this was it is a cross-sectional descriptive study using a hospital-based study, and it was from September 1 to September 14, 2020. And the survey tool was adopted from the Critical Care Society, which was developed for low and middle-income country, with some modification to adopt it to our country. And 22 trained data collectors were recruited to deploy them all over Ethiopia, and funded by Ministry of Health, and IRB was obtained from Debre Birhan University, and permission was obtained from all hospitals, and the descriptive statistics was done. So the result, at that time, we had 53 hospitals providing ICU, and 2 of them was totally dedicated for COVID. And so that time it was difficult to involve them, and we involved 21 ICUs in Ethiopia, which was close to 95% of the ICUs in Ethiopia. Most of the ICUs were located in teaching hospital, almost half. And the beds during that time, it was 324 beds for a population of 114. That means almost 0.3 public ICUs per 100,000 population. We didn't include the private ICUs, and this is almost just during the start of COVID, and the effort has increased and the number of beds has increased after that. Most ICUs are concentrated in bigger cities, in major cities, and 1/4 of the ICU bed was located in Addis Ababa. When you see this table, almost Addis Ababa has 10 ICUs. 2 of those ICUs dedicated for COVID was also in Addis Ababa. So almost 12 hospitals were having ICU in Addis Ababa, then followed by Oromia, Amhara, I think 9, and the total bed in Addis Ababa was 81. So the highest number of beds located in Addis Ababa. While in some regions, the number of beds were low. Some in Afar, Redwa, they are having only 1 ICU, and some of the hospital, like in Somalia, they are having only 4 ICU beds during that time. So most of the ICU capacity were being concentrated in ICU. You can see from this map also, most of the ICUs were concentrated in central part. Even in Oromia, most of the ICUs are located in highlands or central parts of Ethiopia, even in being in Oromia region. So regarding the ICU equipment, the availability, almost 63% of the ICUs beds are having only the suction machine. So they are having shortage in suction machine also, and the 3 basic recommended non-invasive monitoring like blood pressure apparatus, pulse oximetry, and ECG is available only in 33% of the beds. So patients or beds are sharing this equipment for monitoring purpose. Limited capacity for ventilation that time, and invasive monitorings are only available in 3% of the centers. And renal dialysis is also available in only 8% of the ICUs. And the ICU bed had only 85% of the ICU have cylinders. This was a problem in most remote hospitals. The only central oxygen being functional at that time was St. Paul's, only 1 hospital. The others were using cylinders, and they were filling oxygen in major city and transporting to the respective ICUs. And most mechanical ventilators were available in Addis Ababa. So regarding the equipment, so ECG is available in 96% of hospitals. The ICUs also have ECGs, BP apparatus comparable. Pulse oximetry available in the hospital, but when you compare to the beds, it was low, and most equipments are available rarely in the hospital. Oxygen pipes were also rarely available. When you see in regions, so as you see in Addis Ababa, the total ICU bed capacity is high in Addis Ababa. The number of ICU beds is also high in Addis Ababa. So there are beds without monitoring capacity in Addis Ababa. When you have bed also, the monitoring capacity is low. In most centers, they may have the monitors, but most monitors were not functional, or they are not completely functional. That is why these centers are lacking, these beds are lacking monitors. When we come to the design and structure of the physical space, we were comparing their design and structure of physical space, comparing to the standard, which was the 12 parameters set by the International Federation of Intensive and Critical Care Medicine. When you that federation has classified ICUs into 3, level 1, level 2, and level 3 ICUs, and there were 12 criteria to fulfill for level 1 or level 2 and level 3 ICU. Most of our ICUs are in level 1, and 9 of our ICU are in level 2. So actually, none of the ICUs were delivering level 3 ICU care. So, and most of the ICU were having less than 6 bed. As you know, less than 6 bed ICU are not cost effective. At least we have to have 6 bed in our ICUs, but 29, almost more than half of the ICUs were having less than 6 bed. Regarding the availability of a skilled medical professional, more than half of the hospitals have no critical care trained senior, especially they are not dedicated to ICU. And even though most ICUs are having one-to-one nursing to patient ratio, but most nurses are not having critical care training in their undergraduate training even medical professional doctors were general practitioners were not having critical care training in their undergraduate training. So there was a skill gap, and the other is most of the physician, critical care trained physician, more than 50% of the Ethiopian capacity were located in Addis Ababa. So they are concentrated in Addis Ababa. And the respiratory therapists, physiotherapists, and nutritionists were in none of the ICUs. These professionals were dedicated in the ICUs. Some 9 hospital reporters they have in the hospital, but these professionals were not dedicated in the ICU. So most of this job is expected to be done by the nurses in our ICUs. And only 7 hospitals have regular academic activity for their staff, and almost 80% of the hospitals have no infection prevention control or program to monitor the infection prevention practice. So they had some of the hospitals have no access for hand washing. They have water, but most of them have not continuous water in their ICU. And some of the hospital, almost 55% of the hospital, have no separate and clean and dirty utility room. And the QI project is not available almost in 80% of our ICUs. So as you see, mostly the critical care baseline assessment was not promising. It was low. So there is a need for expansion of our ICUs. Of course, most sub-Saharan African countries have less than 2 bed per 100,000 population, except like South Africa and all. Uganda have lower than our 0.3 beds per 100,000 population, but most other countries have higher beds than ours, including South Africa, which have 8.9 beds per population, per 100,000 population. You can see like Germany have close to 30 ICU beds per 100,000 population, and South Africa has, as we said, 8.9 beds per 100,000 population, but we are having almost 0.3 beds per 100,000 population. Recently, we are close to 0.4 beds per 100,000 population. So there is a need for capacity building to train and the training of clinicians and nurses. This can be with short-term trainings, mentorship and coaching, and the spoke and hub model, so that the local better ICUs can help the smaller ICUs, and improving the availability of essential equipment and supplies. So this needs investment. And even though Uganda is having lower beds than ours, they are having more equipment and renal replacement than our ICUs. And we need standard policy and guidelines for the standardization of our ICUs and monitoring of our ICUs. And we have to redesign the structure of our ICU. So how can we change this situation? So the situation was very bad. So there was a huge effort from government and Ministry of Health, especially Emergency and Critical Care Directorate, to change this situation, because there was a pressing need and need from COVID care from a surge from COVID. So one of the methods selected was mentorship and coaching. So we will see whether mentorship and coaching is working for Africa or resource limited setting. The other method was spoke and hub model. What we did was selecting a better ICUs and connecting them with the smaller and worst ICUs, so that they will help each other during referral and equipment sharing and knowledge sharing. This was the effort, and we haven't done the assessment whether it was working or not. And the other was purchasing of equipment. So there was a huge investment to purchase mechanical ventilator and other all equipments from government side. The other is improving oxygen availability. So in all direction, almost doubling of the oxygen production of the country, and 20 ICUs were being opened since this assessment. Essential equipment was purchased for these 20 ICUs, and they were opened recently. The other is training of short-term training of general practitioners and nurses. so that they can function in ICUs. So among these, we were interested to assess. The other effort was collaboration work, increasing government focus, and there was a global fund, non-governmental organization, support from hub hospital, those hospitals who have a better capacity, and the professional societies also supporting, including our society, emergency and critical care society. So we were interested whether among all the efforts, whether the locally driven clinical mentorship and coaching, which is implemented by Ministry of Health with huge investment, whether that effort is improving the advance of critical care service among those smaller ICUs. So mentorship and coaching by definition is on-site training system under which a senior or more experienced professional, so that assigned to act as advisor or shadowing the clinical activity in the junior professional and the smaller ICUs. So as we have seen from the baseline assessment, Addis Ababa has a large amount of emergency and critical care or ICU trained professionals, including nurses. So this professional can mentor and coach smaller ICUs, so that those smaller ICUs become a better in a better situation. So there was a support from non-governmental organizations, including JAGPAEGO, Global Fund, and professional societies, but mainly this was the project from Ministry of Health. And whether this mentorship and coaching was really working or not was not known. So we went to assess the role of locally driven, because we are not getting experts from Western nations and all. Locally driven, those professionals who were working in Ethiopia and know the problems in Ethiopia, and coaching and supporting those smaller ICUs to improve critical care situation in Ethiopia. So the study design was mainly qualitative study with in-depth interview of the Mentee hospital leadership and observing the ICUs from baseline to the end of the mentorship period. So the 31 ICUs were included during that mentorship period, almost 6 months period. And Mentee hospital was selected by the baseline assessment, which I have presented earlier, and 24 ICUs were assessed whether this mentorship and coaching is working or not. So the role of the mentors were identified, and a one-day training was given how to perform a mentorship program. So these mentors were critical care trained physician and master's level nurses were selected from the mentor hospital, mainly in Addis Ababa, St. Paul's, Black Lion Hospital, and other hospital who are working in Addis Ababa, and they were deployed to this Mentee smaller hospital for 2 weeks. So the role of the mentors were daily round. They will do round with doctors, and senior nurses were doing round with the nursing team, and they were shadowing the clinical activity during all the working hours and off working hours also. And they will work with the quality assurance team to identify root cause of the selected problems and make sure these selected problems were understood by the quality team and the hospital, and there will be a culture for a change, for future change after the end of the mentorship program also. And these mentors also will do daily systematic audit of the randomly sampled patient record and communicate with leadership, including the regional leadership, the Federal Ministry of Health, and the hospital leadership, so that there will be infrastructure change and they will get leadership focus. And they did a short-term training on identified gap, and during the exit plan, they will write a detailed plan of a role of the hospital, the role of the Federal Ministry of Health, and the role of ICU, so that they will accomplish or do to change their ICU situation. So data was collected by interviewing the hospital and the ICU leadership at the end of the mentorship program, and follow-up visit or site observation of the ICU. And the interview guide was mainly with those 12 parameters adopted from World Federation of Society of Intensive and Critical Care Medicine. So data was analyzed thematically. So mainly 4 themes were identified and presented here. One of it is the impact of the mentorship and coaching program to improve the ICU care, mainly those 12 parameters selected from the International Critical Care Society. So, and the other is its role in leadership and quality of care, and the other theme is impact in utilization of ICU equipment and the challenges were the selected themes from the qualitative study. So the impact, almost the 12 parameter, it's not all in all hospital, but at least in some hospital, all the 12 parameters were improving. The agreed academic activity for nurses and doctors and clinical rounds were strengthened, and most hospital reported the confidence level of staff to manage patients have improved. And the quote from one hospital, it has been 1 year since we have opened our ICU and we have decided not to intubate patients, but now we have started it. They said there was no patient before almost within a 1 year which have extubated from that ICU. So they differ intubating patients. Then the mentor team has increased the capacity of the ICU and their confidence level has improved, and they started intubating patients. So they also reported intensive care unit design was improved. So one of the quotes, this ICU wouldn't have been opened if the mentor team came to our hospital. So there are hospitals which opened the ICU after the arrival of the mentorship, the mentor team. So the Hamuz hospital also increased from their beds from 4 to 10 bedded ICU. So this happened with the technical support of the mentoring team. The other is the leadership and quality service. So there are lots of points raised by the leadership. Some of them are establishment of multidisciplinary team, leadership focus to renovation of ICU setup, improved bed capacity of the ICU setup, the IPC practice, and human resource demand forecasting and allocation. Most of the parameters have improved, but this is not quantitative study, but it has impact on this leadership and quality service. And some of the quotes from regarding the leadership and quality service. So they say we had documents involving protocols and guidelines, but utilization was difficult until all understood their impact. And the other is like infection prevention practice transformed from non-existent and to segregation of waste and to separate utility room. So most the leadership and coaching, the leadership and quality service has improved because of the mentorship and coaching. The other is improvement in utilization or operating critical care basic equipment. So there are equipments which were in the store, which were not being used by the ICU, while they have it in the hospital because of the lack of capacity or confidence in utilizing those equipments. And they have got trainings in how to operate ECGs, defibrillator, mechanical ventilator, infusion pumps, and the like. And they say mentoring and coaching program has helped to exchange equipment among each other. So there are hub hospitals or mentor hospitals which were exchanging or delivering equipments to the smaller ICUs, and there are smaller ICUs which gave some equipment to the bigger hospital even. So we started to use mechanical ventilator only after the mentoring team came to our hospital is one of the quotes from the hospital leaders. The challenges reported was one is a budget constraint because those hospitals need lots of consumable purchasing consumables were difficult, equipments, and also the mentorship and coaching also requires huge amount of money. That was a budget constraint. That is why the mentorship and coaching was only for 2 weeks, and demanding equipment and supplies donation from mentors. So mentors went to that hospital for mentoring and coaching, but some of the leadership were expecting equipment from the visiting team. The other is limited stay of mentoring team, like they were staying for only for 2 weeks, and it would have been better if they stayed a longer time. The other is limited supply and equipment for the team, and the other is location of ICU. Some of the ICUs were located remotely, and consumable, including oxygen availability, was difficult to expand those ICUs because those cylinders were being filled almost hundreds of kilometers away from the ICUs. So those ICUs should avail their oxygen transporting 100 kilometers. So that was so difficult to expand some of the ICUs. These are my the terms we identified. And I think this is my the end of my presentation. Thank you very much.
Thank you, Dr. Mambo. I don't see any questions in the chat box, and nobody raised their hand. But I have a question of my own.
Yes, continue, Dr. Gana.
Okay. So I was looking for people who raised their hands, and okay, I should go on. I wanted to ask, as you have found significant gap regarding human resource, is there any plan in advancing critical care service or intensive care training as a fellowship or postgraduate program?
Thank you, Dr. Gannat. As you mentioned, there are ways of improving critical care human resource capacity in developing nation. One of it is incorporating critical care in undergraduate program, and the other is short-term training for both junior doctors and nurses. But at a country level, we have to have advanced critical care training for as a fellowship program. So it is not related with this assessment and the effort to improve this assessment, but Blackline, Addis Ababa University has started the fellowship program, and St. Paul's Hospital did a need assessment to improve critical care program and almost finalizing the curriculum. I know these two hospitals are going to start critical care fellowship program in Ethiopia. Hopefully in the coming months, we will see fellows in Ethiopia. Thank you for raising that.
Anybody else wants to ask a question? Okay, Munir, you can continue. Munir.
Okay, sorry, I had difficulty in unmuting. So thank you, Dr. Mambo. So I'm Munir. I work at Ministry of Health as a senior technical advisor, and so I know about this QI project, and it's a very good project. And so one of the things, COVID was a challenge, and at the same time was an opportunity, so that we were able to get extra resources we can spend on improving the quality of care and also access to care generally. But saying that, so improving quality of whether it's acute care or surgical process, and QI is, so there are some advantages and disadvantages that we can do. One of the things is that, so just to comment first on the assessment. So we have been doing assessment of the healthcare in Ethiopia and other countries, and most of the assessments have been assessing the input level. As earlier, as they have said, on the Danabedian model, there is an input so that to the work that we do, the human resource, equipment, supplies, drugs, finance, data, and so on. And there is a process of care, and there is the outcome of care. But so in the future, what QI generally has seen is that most measurements in the input, even if we can expand our services, there is always going to be a gap in human resource. Even if you go to high-income countries, they have always a problem of inputs. So inputs should not be measured to assess quality of care. So rather what we should measure is the outcome of the care, and the outcome has three components. One, what is the mortality and morbidity of common disorders in these ICUs? That's the most important outcome that we would be happy to know in these 300 ICUs. what is the mortality from, I don't know, sepsis, hemorrhage, and so on. And the other is what is the user experience here in these facilities? Are people being treated with dignity, respect, and so on? And the last one is, so how is the cost of these facilities? Are people selling their cows, which they used to plow, or their houses to get these services? Are the most important 3 endpoints. And there are some process indicators that as well. So any assessment that you do in the future should focus on the quality of care rather than access to care. Even though access is important, as a poor nation, there is always going to be a gap in access, and the number of facilities and health workforce and so on can show problem to access. But as earlier it was mentioned, nowadays, most people are going to be saved by improving quality of care, or equal number of patients can be saved by improving quality of care than improving access. So your assessment was great, but so when we do next assessment, we should focus on these outcome indicators so that we show that even if there are 300 something ICUs, so people who can have a preventable days could die even in these facilities would be an important finding. And the other is, even though quality improvements are important in improving quality of care, at a grand scale, they are not enough. So we need to focus on producing competent and motivated health workforce, as earlier said, not only giving them training after graduation, and having so there are several other steps that we need to do besides quality improvement. But quality improvements can be a very good tool for associations, for hospitals that can link with others at meso level, at regional health bureau level, at this level. They are, I think, a very good tool. But saying this, I think this was a very good opportunity for also ministry to strengthen the critical care management using the resources from Global Fund and others that were found during COVID. Thank you, Dr. Mambao.
Thank you, Dr. Munir. It was a very good comment. Most of them are comments which we accept. After this assessment, the one I presented with EPHI team, what we did was assessing the quality of care with individual patients, like you recommend. I think I don't have that data to present, but even Emergency and Critical Care Directorate and EPHI has also changed the way of assessing care from input to outcome level. So that comment is well accepted, and it's being practiced in these authorities, and thank you for that also. So the other, I think most of them are comments which we accept. Mainly you raised on cost issue, which was which is becoming difficult currently, especially in private centers. The cost of ICU is too much, which most of the Ethiopian patients are not affording. Even in government hospitals, the cost is becoming expensive, especially in ICU. I think even in trauma patients, when they are being admitted to ICU, whatever the insurance level is not covering which is needed in the cost in ICU. So that part should be worked on, and we will take those assignments. Thank you for your comments.
Hailu has raised his hand. Hailu, continue.
Thank you, Dr. Mambao. So as insider, I'm going to ask a question. I was fortunately part of this exercise, and it was an exciting time because it really mobilized the resource that existed in each facility, and also activated most of the leadership movement. My question is regarding the sustainability, because most of the team stayed there just for 14 days. And with that time, like with a team coming from the center, having the support of the ministry, obviously facilities would mobilize whatever resource they have, and the attention of the leadership at the facility will also increase. But I'm just worried if this is just Hawthorne effect, that's just excitement raised with what is going on because they are under observation, and with time those challenges you raised are not going away, and the frustration is there. It was so palpable. We saw that, especially with remote facilities. So, is there any possible suggestion of a strategy to kind of localize such kind of mentorship or coaching programs so that it could be continuous? I know it is difficult to go from the center to mobilize that much of professional resource. It is really expensive, but is there any possible design connecting them to the local available institutions such as university, hospitals, and networking of other small hospitals?
Thank you again, Dr. Hailu, for this important question. Regarding the sustainability of mentorship and coaching program, I'm not sure the availability of funding for this program, but there is an interest. But I know there is a spoke and hub model where the hospital are being connected, bigger hospital are being connected to smaller ICUs, like the bigger hospital selected, I remember, Jimma University Hospital, Bahar Dar University Hospital, such hospitals where, and our hospital, St. Paul's, also having four ICUs, working or functioning as a hub for those ICUs, so that we will have knowledge sharing and sometimes equipment sharing also. We have seen one of the hospital near to Jimma having excess monitors, excess ECGs, but they are lacking some equipments, and they were sharing with Jimma University Hospital. So there is effort to implement a spoke and hub model, selecting hubs with a bigger ICUs and connecting them with the smaller ICUs as a spoke. There was an effort, and I was part of that. But whether that was effective and being continuously monitored, I'm not that much sure. But I know there were selected hubs, and it was functioning. If I answered your question, Dr. Hailu.
So Lamlam asked the same question. I think you've answered it now. The other question is, is there any action / implementation you have done based on the results to improve the capacity? This is a question that I found on the chat box. Should I repeat it?
You said action, depending on the findings. I think most of the action, including extensive training or short-term training, is all over Ethiopia. Investment to expand more than 20 new to open more than 20 new ICUs, and all mentioned were depending on this finding. I think there was a huge focus, whether it was from this ICU assessment or because of COVID. We have to work on it, but there is a huge effort after 2020 to improve Ethiopian critical care society. So the other question I saw from chat box is, do you assess other professionals that were assigned university for teaching level? I'm not sure this question.
Could the person who asked the question unmute yourself and ask it again, if it's possible?
So one of the questions from Malkamu is, a professional mix, non-physician like anesthetists. Anesthetists were almost the main part of those smaller ICUs. They were the main part in intubating patients, and they were involved in a training. So they were part of the assessment and part of the work. So I think that is the answer. And if there is another question.
Nobody else has raised their hand, but there is, I think, yeah, nobody raised their hand. So if there's no question, should we continue? Okay, there's another one. Were there any graduate in Cascade to other centers? If it's still a work in progress. So nobody raised their hand. So we continue to the next presenter.
Dr. Gannat, sorry, there are two hands.
Okay, I don't see them.
Dr. Munir and Malkamu is raising their hand.
Okay, Dr. Munir, I think. Okay, Malkamu.
Okay, so it's Malcolm actually.
Sorry, it's Malka.
Okay, can you hear me?
Yes, we can hear you, Malcolm.
Okay, so thank you, doctor, for your presentation. I think you mentioned a little bit about non-physician anesthetists and their availability in those lower ICU setup. And I'm also part of that setup. So my question was, what can we do as a non-physician anesthetist to improve this critical care setting? Because there are lots of red tape that prevents us from actually helping this patient and participating in critical care, although might require some kind of training. Just intubating this patient and giving a small amount of help might not be the most appropriate way to help them. So is there any setup, any agendas or from the Ministry of Health or from your research that can help us improve our participation in this critical care setting? Thank you.
Thank you, Malcolm, for your clarification. This important question. You say at the beginning of the implementation effort in to improve this ICU care, the first thing was training and involving anesthetists in this program. So the problem identified at that time was most anesthetists in their center, they come for intubating the patient, but they were not being involved in medical care of patients in the ICU. But in most places, they are the only one to help those patients during difficult time, including airway care. It's not only the airway care; they have to understand the medical care of and manage medical part of the critically sick patients. So we involved them in a training in short-term training. That may not be the only solution to involve them, but in all their centers, they have to be part of the ICU. And that was also what, to my understanding, that was also the direction of the Ministry of Health. But if you ask me in my experience, most anesthetists are not being fully involved in medical care of patients in ICU. They come for airway care or when there is airway difficulty. But I think they have to be integrated in a medical care. In some hospital like Eka Kotabi at the beginning, what I remember is they are part of the ICU, they make round, they will be part of the decision process in ICU. This culture should improve. How can we improve? I'm not sure the exact answer. What we did was they were part of the training in all short-term trainings in ICU. But it should be a culture to involve anesthetists in the ICU practice, especially in those smaller ICUs, because they are the backbone and they are the only one available in those ICUs to help those patients. Thank you.
So the next presenter is Professor Rupert. He's already introduced earlier, but he'll be talking on building local and acute care research capacity and integrating research outcomes into national policies, lessons from the UK and other developed nations. So, Professor Rupert, if you can take the stage.
Thank you very much. So I've been asked to talk a little bit about how we can translate learning about building research capacity in acute healthcare into a global health, low middle income country environment. And I think probably the overriding principle I would say is that the principles, the main theories are, I think, the same everywhere in every type of country. The challenges you have are obviously more severe in some countries than others, and some hospitals than others. And the combination of different types of problems is obviously unique to each hospital, but the overarching principles are the same. And that's important because it means the solutions to our capacity issues can be worked through based on the principles that we've used in other countries. So I think that this is one area where we can be confident that we can share knowledge between high-income countries and LMICs. So the first big principle that I think in particular applies to anesthesia doctors, we're backroom people usually. We're not at the front of the stage, we're not the centre forward on the football pitch. We quietly work in the background, and that's our nature. And so we're not used to walking to the front, taking control and saying, right, this is what we've got to do, this is the problem, even when we can see what that problem is. And so I think for us as a group, we need to remind ourselves that if we see a problem and nobody else is taking the lead in tackling that problem, then we shouldn't be afraid to do that ourselves if nobody else is. Because rather than be criticized or people disapproving of what we do, you'll almost certainly find the majority of people are glad for you to step forward and glad of your contribution, and that they'll value that. Not everybody will. Unfortunately, in research, we do find sometimes that our colleagues are jealous of what we're trying to do, or maybe critical of what we're trying to do because maybe they wanted to do it and they didn't know how. But I don't think you should let that kind of thing stop you. So please don't be afraid to take the lead. Second big principle is how you build your collaborations, that team of people you work with. And it's really important, and I think in particular, it's really important for me to work with people I trust. I have to know when I am involved in projects that are really trying to be world-class in terms of the impact that they have. Average is not good enough. We need to go for really, really high quality research because our patients deserve that. And that means that we're always striving for excellence in the work we do. And that extra pressure means that you have to trust the team around you. But the big caveat to that, the big caution, is that in the great majority of cases in people I've seen where there is a breakdown in trust in a collaboration, it's not so much that people weren't trustworthy. It's much more common that people didn't learn to trust others. So there was a suspicion of one person from another that didn't have any basis. There was no reason not to trust that other person, but they weren't trusted. And so I think that as well as working with people you can trust, I think it's very important to learn to trust those around you and learn to trust their intentions and recognize that when you've got really important shared goals, just because you may try and tackle that problem in a different way, doesn't mean that people can't trust each other. The next big area is about how you engage and manage senior collaborators. And this is an important area because in many projects, more junior staff will want to bring in a senior colleague, either from their hospital, from their country, or maybe an international collaborator. And there's an art to how you collaborate with senior people. As a general rule, good senior collaborators don't mind if you manage them. They don't mind if you organize their time. They don't mind if you give quite clear guidance to them on what you expect from them and what you need from them, because they find that helpful in terms of, they don't have much time available. They don't have much time to work those things out for themselves. So the clearer you are with them on what's expected, the easier it is for them to know, first of all, that they've got the time available to help you. And second of all, that they're doing something for you that you need. So don't be afraid to be quite clear with a collaborator that I'm bringing on board to do a very particular task in a very particular way, and or I'm bringing on board just to give us advice, and you don't need to do anything unless I contact you and ask you a question, or whatever that might be. The other thing about senior collaborators is that some researchers have a tendency to collect them, as if by having lots and lots of senior collaborators, it will somehow generate recognition that your project is of a very, very high quality. But actually that doesn't normally turn out to be the case. And it's much more likely that if you have lots of senior collaborators who aren't very active in your project, that will be considered a weakness, not a strength. So learning how you bring senior colleagues on board, how you give them particular tasks, and how you manage them so that they deliver those tasks in the way that you need is an art in research, as in all things, I think. And it's a good thing to focus on and learn about. My next comment, and I brought this up in my previous talk, and I think Catherine Chu raised a comment about it as well, is that we have a tendency as researchers to become very preoccupied with money and how much funding we have. And in my experience, although you always need some money, you can't really deliver research with no money at all. It becomes very difficult to do that. What you can do much more with is resources. And I think the ASOS study that was delivered out of Africa is a really fantastic example of that, because that project wasn't really delivered with money. It was delivered because people shared resources, whether that's local investigators and individual hospitals agreeing to help because they believed in the project, or whether that's because someone gave up their time to do the statistics, or whatever it might be. The majority of the ASOS study was run for free by people sharing really important resources. And so you're most likely to make progress by asking for resource, not asking for money. Now, that doesn't mean you can't do research with no money at all. That's not what I'm suggesting. Just that you probably need more resource and less money than you might necessarily think. So always consider, what do I actually need? And if I'm asking for help, do I need to ask for money, or do I need to ask for the resource itself? Because often asking for the resource can be more successful. And applying for grants and seeking money can be very, very time consuming. And it's very easy to do more work getting the money than the work needed to do the research itself. The next big point, and I say this to my colleagues a lot as well, is organizations are made of people. So it's very common to hear people say, this university has decided this, the government has decided that, our hospital said this, as if those organizations were sentient beings that made decisions. But that's very unlikely to be true. What's much more common is that those organizations are built from people. People are the bricks that they consist of. And that somewhere within that organization, there is a person who's made that decision or is responsible for that decision, who you can engage with, who you can reach out to as an individual human being, who you can try and understand as a human being and negotiate with them as a human being. And that if we do that, we can often find that we can influence those people. So people who work in organizations often feel a very heavy weight of responsibility to support others. And we may think that's not true, but it usually is. And that sense of responsibility means that when people come to them for help, they want to help. And often when they don't help, it's not because they don't want to, it's because they're unable to, or because we've asked for help in a way that makes it difficult for them. So understanding those people, understanding how could they help me? What are the drivers in their job, in their role, that might make it harder or easier for them to help me? And by thinking about how you make it easier for them to help you, you increase your chance of getting the support you need. So thinking about people, not about organizations, I think is a really valuable approach. The next point is that success is the biggest driver for success. So if you have a small early success, you prove to people that you're capable of leading, you're capable of delivering, you demonstrate your work ethic, you demonstrate a whole range of things about you that are hallmarks of success. And if people see you and go, well, that person has delivered a small research project and they did a really good job, it was very successful, it was on budget, or it was on time, or it was really high quality piece of research, they're much more likely to be confident in you. And if they're confident in you, they're more likely to invest resources, they're more likely to share money, they're more likely to publish your paper, they're more likely to provide things that you need. So don't underestimate the value of a small success as a driver for the next bigger success. And often in research, you start small, you deliver something that is an easy win, and then you build on that easy win and go for bigger and bigger, more ambitious projects as you go. And in that way, small successes can deliver very, very large successes indeed. And I think that's a valuable way of thinking about building a research group. This is a lesson I have learned the hard way and the easy way on more than one occasion. When you're doing research, the data is the research. If you don't control the data, you don't control the trial. And I think we've heard this statement in various ways today. We've heard about international collaborators coming into our hospitals, doing research with a data resource that we hold locally, and perhaps not giving any credit to the people that have collected those data, or who perhaps are deserving of credit and recognition. And I think Catherine made those points really well, and I think that's really great that she highlighted that. But remember that controlling the data is the way to control the way research is conducted. And if you hold the data, and if you are the person who controls the access to data, it allows you to lay down rules about how the research is conducted. And that might be rules about quality, it may be rules about research ethics, it may be rules about your collaborators being professional and fair and equitable in the way that they work with you. So don't underestimate the power of controlling access to data. And remember that if you negotiate what you need in a research collaboration before you agree to share data, you're much more likely to get the things you need out of that research project, whether they're things you need personally or whether they're things that you need for your organization or for your team. Use every opportunity to demonstrate integrity. Reputation in research is everything. We live and die on our reputation as researchers. When we send our research to a journal and there is a question mark over some data, there is a problem with a paper, which are very, very common problems. That's not unusual, even for very good groups, to write a paper that there's a problem with. The first thing that a journal editor or a peer reviewer or really anybody will think is that researcher somebody who has a good track record of behaving in a very professional way? Are they honest? Do they have a track record for being open and sharing problems with their research, discussing limitations with their work in an open way, as well as discussing the strengths? Do not underestimate the value of demonstrating your integrity, which often means you are prepared to share and discuss the weaknesses in your own work, amongst other things, because it's a real strength, and you will develop a reputation and a track record for integrity, which people will value about you. And when there becomes a difficult moment with your research, they will trust you because they know and have seen that you behave in a trustworthy way over and over again. And so don't be afraid to demonstrate that. I think this is an important one. Don't confuse the research you can do with the research you need to do. Often we have a research question that's very, very important, but we don't have the resources to deliver that research. And so we design a project that's maybe too weak. It's not strong enough, it's not big enough, it's not robust enough to answer the research question we have. And it's quite important when we are doing that we recognize it, that we don't feel ashamed somehow that we need to pretend our research is robust when perhaps it isn't, because that's a common problem. It's better to accept the research is not big enough, strong enough, robust enough, and maybe go away and do a smaller project first. And as I said earlier, build on that success so that you can get the resources you need to do the larger, more difficult project that you need to do. And being open with yourself that maybe the research you propose is not the definitive research that you know you need to deliver. And instead having a strategy of delivering a series of small projects that lead up to a big research project, rather than trying to do a huge research project in one go. And in general, research is more successful if you take lots of small steps than a small number of big steps. Interpretation. When we do a research study, we all want to say that it's incredibly important. We all want to demonstrate the impact of our work by telling people that it's really shocking, or it's really important, or it's really exciting. Well, most of my research is quite boring. And I usually find that if I try and say it's exciting, I mislead people. I maybe highlight a finding that's not the main finding, or maybe I mislead people in what my research actually means for patient care. And it's not helpful to mislead people about what your research finds. Even if they can go and read it properly for themselves and work it out, they'll be very reliant on you as a researcher to interpret your research for them. So don't be tempted to try and have a big, exciting headline if that headline is misleading in some way, because it can be very counterproductive for you, and it will cause you problems with your next steps in that theme of research that you're undertaking. I think another point, and again, this has come up more than once today, is to role model equity and recognition of your collaborators. Always make sure that you set your research up in a way that the little guy gets recognized, because big collaborative projects rely on local investigators in their own time, usually, giving up something else they might do. Maybe it's an evening with their family, maybe it's a day out with their children, to do research, to do work on your research project, and to recognize that valuable contribution, that sacrifice people have made, in particular through authorship or study group membership that leads to listing on PubMed, amongst other things. That recognition is incredibly valuable to people. And it's something that may not seem very important to us as research leaders. It sometimes means the world to somebody who's given up their time to help collect data in an individual hospital for us. And by creating a culture where all of those people get recognized for what they do and their contribution is recognized as invaluable, that we can't do without those people, then the more we recognize and celebrate them, the more they're going to want to come back next time and help us again. And amongst them may be some future successful senior research leaders. And we really, really need more research leaders everywhere, but in particular in low and middle income countries. Finally, dissemination. When we tell people about our research, sometimes there's bad news. And in particular, if you're a politician or a civil servant in charge of healthcare, if somebody does a research project, such as the excellent talk we've just heard, discussing critical care resources, there's some very honest and straightforward information there, but it's mostly not good news. It's mostly that we don't have enough resources and things aren't going well. There are some good news stories in there, but a lot of the story is bad. And you can imagine how a journalist could write a very negative newspaper article or a YouTube article about those findings. The best way of dealing with that is to go and see those policymakers, go and meet the politician, go and meet the civil servant and say, look, we found these things about critical care or whatever else it might be. And we think that it's really important, but we don't want this to undermine you. We want to work together with you to show that we're going to use these findings to make, you know, our hospitals better, our healthcare system better, the world a better place. And we want to work together with you to do that. That allows those people to use your research as a success story for them. It allows them to go, I'm happy to have this opportunity to identify problems with our healthcare system. And we already are doing these 3 things that are going to help solve the problem. It allows them to turn your bad news into qualified good news for them. And that means you build a relationship with them. That means they trust you. Most of all, that means they're going to help you implement your findings of your research and work with you in the future. So bearing in mind that it's very easy just to share a research paper before it's published and to talk to people about that. That can be an incredibly valuable approach in engaging policymakers. So I'll stop there. And again, I just want to highlight the fantastic successes of research in perioperative care and not only through the Apple group, but also through individual national collaborations. I think that there's some absolutely superb work going on. I'm delighted simply to be here to talk with you about it. And I'm really impressed, and I wish you every success with your next projects. Thank you.
Thank you, Professor, for the nice presentation. I'm looking for participants to raise their hand if there is any question. Please proceed. Would you like this participant to ask question? You've raised some interesting points in your presentation. Some of the things that I found interesting were, don't confuse the research you can do with the research you need to do. So as young people who are interested in research, we tend to be confused and just look at the things we can do when we don't even know if we need to do it. So thank you for that advice. And the other thing is don't fall for tabloid findings. So you're right, we tend to be overly dramatic in the findings, and the simplest things could change many things. So there's, I think there's a comment from Alamayo, Dr. Alamayo. Thanks for the insightful presentation. So any questions?
I think Bruce has got a question there.
Okay. So he can continue.
Thanks very much, Rupert. Thanks, Dr. Ganesh. I just wanted also to reiterate that I think, Rupert, the principles you've raised are super important. And the principle about tabloids and media, and that I think is extremely important. My own personal experience with, the work with ASOS and particularly with the cesarean deliveries was, how do you get a message out that women are doing so badly, and it's so important without it being framed in the wrong way. And I know I had a lot of reporters wanting to report on it, but the whole time you could see they were looking for an angle to blame, which is extremely destructive. And my advice just to the group is, I think a lot of time when we do end up speaking to the media, most of the time, unfortunately, we're not going to have good messages. We're going to have advocacy messages. And just be careful that you don't get sucked into trying to ascribe things which you never actually studied, because that really will become the main part of their story, and it'll be very destructive for the group. So one has to be, very careful. And I think that point, you don't really realize until you're almost in it. But fortunately, I think we've managed to steer clear of that as a group, and that's been very good for all of us.
Yeah, I agree with you. There's always a positive way of spinning a negative message. And the thing with journalists is to think about, every sentence, every little cluster of words. They don't take a paragraph of what you've said. They take a little cluster of words, but always trying to spin things like, if you found something that was a high mortality rate, you said we've got an opportunity to improve outcomes. It's always turning the negative into the positive. It allows you to avoid that particular risk.
I think, yes, you've got to appeal to their greater good, because you can see their normal modus operandi is the opposite. And you've got to say, this is really the good of society. You have to present this in a positive way.
Yeah, Salome has a question, I think.
Thank you very much. Also, congratulations to everyone for this excellent meeting. I just wanted to add as well to what Bruce was saying, and I found that in my experience, having recommendations ready and volunteering them alongside the problems, even before they ask for them, immediately diverts the conversation, and they're now saying, what can we do? What should we do? So I was just adding that, conversations with media, you direct them and go in there with answers, and not just the problem, but recommend. It's an excellent opportunity to give recommendations, because everyone will always know will want to know what should we do next now that we know these things.
I couldn't agree more, and I think, of course, it's your opportunity to highlight the next step. That media coverage. We should already be thinking about the next thing that we want to do, the next study, or how we're going to implement our findings. I completely agree.
I think it's a closing remark by Dr. Alenta.
Hello, everyone. Thank you so much for the wonderful session. My name is Alenta Gabriyesus. I'm an emergency physician and currently working as Director for Emergency Injury and Critical Care Directorate at the Ministry of Health. I'm also coordinating the current conflict-related health emergencies. I've had ground level experience as a clinician, educator, and have been part of several implementation research here at the ministry and outside. So it gives me great pleasure to be here, part of this session, and I would like to thank everyone for the lively and interesting discussions we had today. It's important and very practical points have been raised. It's been such a wonderful and fruitful discussions. I just would like to highlight or reiterate some of the key takeaways from the discussion we had today. those points have been discussed one way or the other, but I just wanted to give some emphasis on the first one is knowing or identifying the priority areas for research in the acute care continuum in emergency critical care on the point. So defining those priority areas would be key. The second one would be building local research capacity and meaningful collaborations with the trust and the meaningful collaborations between different collaborators here within the African setup or outside. The third one would be creating equitable research collaborations that are in line with local needs and producing sustainable results and value adding to improving the patient outcomes. We've also mentioned a lot on these areas. The prior speakers have mentioned valuable inputs in this regards. The fourth would be that translating evidence to policy and practice. And the fifth one would be continued advocacy and getting the message out there, reaching the wider networks in this regard would be. These are some of the key takeaways or highlights I took personally, and I hope the audience also took these key takeaways. So considering what is out there, what is the supportive environment out there? Is there one? I would say yes. And it's also starts from, it also ranges from the policy decisions and strategy level facilitations. So there have been several efforts by the Ministry of Health to integrate these areas and make these priority at the highest level, at the policy and strategy levels. As you know, the ministry has also launched several strategies, one of which is the 5-year National Emergency Injury and Critical Care System Strategy, which also highlights the need for evidence generation, evidence-informed decisions, and institutionalizing this culture. So yes, there's a positive environment for collaborative work from the ministry side. There are also several other strategies in support of this work. I would like to mention the ministry has also started this major city emergency injury and critical care improvement program, which mainly focuses on having customized high impact interventions in selected cities, and this provides a unique opportunity for academia to collaborate between the academia, the regional health bureaus, the local administrators, including the political leadership, because we have to have the buy-in to implement those changes and have them in a sustainable manner. So I just wanted to mention that there is a great foundational work that is already available to build on and continue the research questions and taking these steps forward. My colleague Dr. Munir is also mentioning that there's also the ministry is also establishing a separate research unit within the research unit, which would guide the national efforts, the national priority setting, and to facilitate such efforts. So that those are really positive environments we have. Apart from that, there are several surveys, national surveys that my colleague Dr. Mambao has mentioned earlier. These have been done in collaboration with the Ministry of Health and different societies and professional associations. So targeted mentorship and coaching, need-based assessments and supports are being done at national level. And of course, we're also working on the sustainability efforts and very open for inputs in this regards. Several guidelines, SOPs, hands-on trainings, capacity buildings are also in the pipeline. So just wanted to mention what's out there, which would fuel this collaborative works from the ministry sides and as well as in the acute care system. Apart from that, there are also numerous opportunities and possible opportunities for service for different stakeholders that have been involved in this, that are involved in this work so far. There are so many areas for improvement, and I also want to bring to the team's attention the area of this acute care continuum range to the out of hospital and the pre-hospital care and the community needs as well. So I also would like to open this up as another research question to be addressed, because there's a dearth of and paucity of data and evidence in this regard, especially in the low and middle income countries and the African context. So I think the next steps should be well thought of, and we should also keep this momentum and take the discussions to the next level. And I would suggest we do have different stakeholders attending this conference. For the service providers and clinicians, I would suggest an increased focus in clinical effectiveness and cost effectiveness of care, designing quality improvement projects which would benefit their local institutions and facilities, and bringing those lessons learned out there so that the patient care could be improved, as well as the evidence could also be generated and scaled up to different facilities, and changing the daily challenge into unique opportunities for continuous quality improvement would be something to consider. For those working in academia, the customization of high impact interventions to suit the low and middle income context or setting, it would be very key, and it's very untapped. Designing of curricula for specialty programs, not only for physicians, but also for nurses, for anesthetists, other professionals working in the acute care system would be food for thought and something to consider. For institutions and universities, building on the collaborative area and also experience sharing, designing exchange programs, building local capacity, building the local capacity for research as well as grant writing, focusing on the financial aspects and cost effectiveness of care, because when we bring the sustainability piece into the picture, we still need to deal with such questions as well. And also, of course, as I've said earlier, extending the questions to the out of hospital or the pre-hospital context to avert the delays in perioperative setting, the critical care, surgical care, and also the delays in achieving the desired patient outcomes. And also, I would also like to call upon the several networks to really leverage these platforms for capacity building, sharing experience, and also obviously the conference organizers to have these key action points and have these key action points formulated, continue the discussions, craft for further collaborations, and also keep the regularity of such platforms, because these are very helpful and fundamental for growing addressing the growing needs. And obviously, the Ministry of Health, I would like to affirm that we have the continued commitment to institutionalize such efforts and use evidence for policy making and strategic decisions, and the guiding quality and sustainability of care. We're very interested in conducting implementation research and implementation science. So just wanted to reiterate this and affirm the continued commitment from the ministry side. Last but not least, I would like to thank all distinguished guests for your time, excellent presentations, for your invaluable experiences, and for your time. My appreciation on behalf of the ministry and my other colleagues. Also, I would also like to thank the participants for the lively discussions and participations, very important comments and feedback, and obviously the moderators for excellent moderation and facilitation of the sessions, and the conference organizers for making this happen. My heartfelt gratitude also goes to them. So I just would like to leave you with this challenge. I mean, what can we do with what we have, and how can we make the points that we've addressed in the path to contribute towards addressing the bigger picture of universal health coverage, protecting people from health emergencies, having a responsive and meaningful system which would address the needs of the individuals and patients. So I would be leaving you with this question, and it's definitely time to build African acute care research capacity as a priority in global health. Thank you so much for having me. Thank you. Over.